Welcome to our webinar series for professionals.
So everything relevant to women and female patients is the main focus today. So yeah, we woke up to a bit of a disaster because, well, I think it's turned out to actually the much better. But the presenter that we have promised you all should present was not able to present anyway. But I have a better option for you. So I have Dr. Jaclyn Smeaton with me. She stood in. So remember, the time difference from Copenhagen and Oregon is like 9 hours. So I managed to get hold of the CEO, president of Precision Analytics at 5:30 in the morning. And said we have to change because it's just not going to be possible. So but luckily Jaclyn was like, I'll do it, no problem, can't wait, it's going to be great. So yeah, that's how things can happen across countries and what have you, how we manage to help each other. So but you are in for a treat, I know for sure. So of course we are recording, and the slides will be shared with you when we send out the recording as well. And then I just want, for those of you who just joined a little later, just want to say and remind you that we have the in-person event in London coming up 26th to 28th of April. I checked flights, at least from Copenhagen to London, they're real cheap, so cheaper than a train ticket, I think, nearly. So you might want to check it out anyway and join us. It's going to be fun to see you all there. But if enough of my talking, just one last thing, to put your notes and chat with each other in the chat area. And at the end of Dr. Smeaton's presentation, we will do the Q&A. And just Dr. Smeaton is a naturopathic doctor from Bastyr University in Seattle. And she is the Chief Medical Officer for Dutch, or Precision Analytics. So Jaclyn, you're welcome to share your screen and put your slides up. And we are eager to learn. I'll mute myself, but if there's any technical things I can hear, then I'll put it in.
Great.
But I'll let you have the mic.
Thank you. So it's so nice to be here. Thank you so much for pivoting and welcoming me so graciously. Yes, I've been in practice for about 20 years now, and the last 15 years have been exclusively dedicated to reproductive health and women's health. So this is an area that's near and dear to me, and working with Dutch has been such a wonderful fit for myself and for, my interest area. And so I'm very excited to be able to talk with you today a little bit about really one of the most valuable areas of health that we see the Dutch test applied, which is perimenopause and menopause. So I'm going to walk you through really a little bit about what's happening physiologically, but we are going to focus mostly on the Dutch test and how it's so helpful and usable during these periods of life. So let me just try to I have a funny little Zoom window over here. There we go. Let's just do a quick review first. What we're going to be talking about, kind of these key hormone players. Just as a reminder, you do have cholesterol as a very important backbone to all of these hormones that are made. And, we're going to be focusing really on the changes that we see with progesterone and then the estrogens here. You can see estrone and estradiol. These aren't the only hormones that are important during perimenopause and menopause. In fact, androgens like testosterone and DHEA and the metabolites of androgens are also critically important. And we'll talk a little bit about those later on in the presentation as well. Now, just as a reminder from a physiological perspective, I'm sure this is a review for many of you, you have the brain, the hypothalamus, and the pituitary gland that are really orchestrating the release of hormones. So you can see here, this is in a cycling female. Gonadotropin-releasing hormone is coming from the hypothalamus, which communicates to the pituitary gland. And then depending upon actually the frequency of the pulsing of gonadotropin-releasing hormone, because it's released in spurts, the pituitary knows to make LH or FSH, And those communicate with the ovaries, which in return produce estradiol and progesterone and a series of other hormones as well, in order to orchestrate the changes of follicular maturation, release of an egg, thickening of the lining of the uterus, and sustaining of pregnancy. Now, we do have those really important hormones of gonadotropin-releasing hormone, LH and FSH, and estrogen and progesterone. And as we're going to talk about the changes that occur during perimenopause and menopause, the biggest impacts that we see is the decline of estrogen and progesterone, those ovarian hormones, where you see a rise in the pituitary hormones, because when these ovaries stop making the hormones in response to stimulation, they're no longer responding, the brain almost starts to yell. That's how I describe it to my patients. If you're a parent, you might know what I'm talking about. Which is you ask your children, please go make your bed, please go clean your room. And it's always a polite tone and a normal voice. But if they're not responding to you over and over and over again, the natural tendency is to get more forceful, maybe louder or a stronger message. And the brain's doing the same thing with the ovaries during the course of perimenopause and into menopause. So you'll start to see particularly FSH come up and up, higher and higher as women are approaching menopause. Now, I love this image of the beautiful menstrual cycle. As you start to see the changes in the pulse frequency of gonadotropin releasing hormone, this shifts throughout the cycle, really depending upon what it's trying to get the pituitary to release. You can see those changes in LH and FSH, including the spikes that you see in LH that trigger ovulation. And then, of course, in green and purple, the rise here of estradiol, which is actually still quite high in the second half of the cycle. And then the progesterone, once ovulation happens, progesterone rises and peaks about 7 days after ovulation. Now, typically when you run the Dutch test on a cycling female, we are trying to catch this peak time. So we generally recommend between days 19 and 21 in a cycling female for a woman with a 28-day menstrual cycle. So about 7 days after ovulation. And that's because this time right here is the best time for us to really compare progesterone and estradiol and all of the estrogens to get a sense of that kind of ratio. And that's important in the perimenopause time too, because we are still trying to catch this window of 7 days after ovulation as best as possible. Now, I think there's a common misconception that I see out there, which is that perimenopause is a slow, gradual decline into a menopausal state with low hormones. And it actually couldn't be any more different from that. Overall, you do see a decline in those hormones, but what you tend to see is these fits and spurts. And you can see this here. I love this graph, just demonstrating the up and down nature for both estrogen and progesterone. It actually looks most similar to puberty, those years where us poor women, with all we go through in our lives, we have to go through puberty a second time on the other end of reproduction, is how I think about it, where you start to experience the changes. And really that fluctuation helps explain why puberty and perimenopause can feel so similar. The emotional dysregulation and kind of changes where you might feel fine 1 minute and very emotional the next minute, the changes in skin, the changes in hair, all of those things from the hormonal fits and spurts really are interesting, and how that perimenopausal period can really look a lot like puberty, because from a hormonal perspective, we do see that fluctuation pretty similarly. So we are going to focus in today on those perimenopausal and postmenopausal years. Now, before we dive in, I want to just kind of frame the conversation by looking at a Dutch test report for a cycling female. I'd love to know if you guys can maybe put your hand up or note in the chat, how many of you use Dutch test in cycling females today? I'd love it if you can just pop it in so we can see, raising your hand is great, popping in the chat. Okay, so a lot of you are very familiar with this already, which is wonderful. So I want to orient you to how I look at a Dutch test in a relatively quick way for a cycling female. So really the first thing that I'm looking at here is the amount of estrogens, which you can view here, this is page 3, and the amount of progesterone. Now with this, we're looking at kind of the relative positioning of the dial. These dials look at where women fall on a reference range of all women that are cycling that we test in the lab. So in this case, for example, you can see the progesterone relatively is slightly lower than the majority of the estrogen, just based upon the positioning of the arrow. That's the first thing I want to look at, is there more of an estrogen dominant state, progesterone dominant state, or a balance? So in this particular case, I'm seeing a little bit of a preference towards estrogens compared to progesterone. That might mean that there could be a problem with estrogen metabolism. It could be that there's too much estrogen being made or not enough progesterone being made. There could be a lot of different reasons for that. The next thing that I like to look at is the metabolism. I'm not going to get into that too much today, but I'll just touch upon it that here we do look at phase 1 of estrogen metabolism with these 3 arrows. This shows a preference for producing a 16, a 4, or a 2 hydroxy. In this case, we're looking at estrone, but it's appropriate across all of the different kinds of estrogens. And the reason why this is important is that this 4-OH-E1 metabolite with the red arrow can actually cause DNA damage. It's pretty active as a metabolite, and it can bind to DNA and cause trouble. So it's kind of like the party metabolite is what we think of. And we really want to see relatively less of that. In this particular test case, the 4-OH is relatively lower than the 16, which you can see up here, and the 2. Now, the 2 marked in green is the preferred pathway, the safest pathway for elimination of estrogens. And the 16-OH is still pretty neutral, but it's very potent and active as an estrogen still. It can bind to estrogen receptors and stimulate tissue growth. And so we tend to see more 16 in circumstances where women have more tissue growth, things like endometriosis, fibroids, breast tenderness. So it can be really relevant when you're looking at a patient's picture as well. The second piece we look at here is methylation activity. This is phase 2 of estrogen metabolism. And you can see in this case, again, methylation is a little bit sluggish. And so that would be another area that we might want to take a look at. So like I said, that's not the focus of the lecture today. Just want to kind of orient you. So I'm looking at estrogen and progesterone production. I'm looking at estrogen metabolism. And then I like to take a look at the androgens here in the white section. So you can see in this case, this patient's testosterone still looks quite good. DHEA sulfate, again, looks good. And you can see here, when we look at the metabolism of androgens, that they really prefer the 5-beta pathway, which is less androgenic. Now, that's really relevant when we get into menopause and how you might help a woman with menopause, because androgen metabolites are still active. And so when we look at things like if you apply a treatment, or especially something like hormone replacement therapy, metabolites really are important to get the dosing right, not just looking at the parent hormone. Also on the last page of the Dutch test, I also like to point out, I call this the bonus section. This is our OAT tests. And these are a series of different organic acids, markers for different neuro-related markers, and some additional markers for things like melatonin and overall oxidative stress. Always great to take a look at these, because this is one area that I look for like the root cause of dysfunction. And we're going to talk a little bit more about that in regards to peri and postmenopausal females as well. But biggest thing to look at here is when you're looking at a Dutch test for a reproductive female, you would expect that their progesterone level and their estradiol level is in this green zone here between the stars. You can see that right here on the key, that this green zone is the premenopausal cycling female range. The stars represent the low and high limits for what we consider to be normal. And then the purple is the postmenopausal range. Now, this is helpful because when we look at postmenopausal female Dutch test, which I'll walk you through a case for that today, we would expect that on no therapy, you'll see estrogen and progesterones in that purple range. Perimenopause, you kind of could expect to see it anywhere. So let's go ahead and dive into that a little bit more. The last thing on the reproductive test that I want to point out is this adrenal hormone pattern. Hopefully all of you are looking closely at that HPA axis. The HPA axis becomes even more important in perimenopause and postmenopause, and I'll get into the reason why. But really what you're going to be looking at here, this actually looks like a pretty nice curve, is you can see this is a Dutch plus. So the first 3 samples are taken in the first 60 minutes in saliva. And then we still have the afternoon and night measurement. And you can see this high climb and decline, which is a cortisol awakening response. And then the slow decline throughout the day, which is what you'd expect to see. And in this patient's case, really all of her salivary cortisol production, her urine metabolites, everything looks really great for this particular patient's case. I do want to call out just a couple of pieces about cortisol in the reproductive years to just frame this up, because cortisol and the HPA axis become very important in peri and postmenopause. So first of all is that cortisol actually tends to be a little bit higher during the follicular phase of the menstrual cycle. This can lead to women feeling an increased feeling of energy and well-being. Now, you might hear this because people talk about it when it comes to workouts and exercise, that the first half of the cycle, you really should go stronger, whereas the luteal phase, you might want to kind of bring it down a little bit in intensity. That's because there's a strong interplay with estrogen and cortisol that provides further support for energy. That's really important to think about, because later on, when you lose your cycles or estrogen is declining, you don't get that extra benefit of that relationship of estrogens and cortisol. So that can really contribute to women not feeling as great in the peri and postmenopausal years. Also, during the luteal phase, when progesterone comes up, that can lower cortisol, even when stress remains the same. Progesterone actually has a little bit of a suppressive effect almost on cortisol. And that is why in cycling females, that second half of the cycle, particularly those menstrual days, 3 or 4 days, when progesterone's really starting to decline, there can be a feeling of a lower stress tolerance, maybe a little bit more emotionality. And actually, this is something that many women feel totally fine managing throughout their cycling years, but it can be one of the first signs of perimenopause coming, is PMS, that premenstrual syndrome, and that emotionality 3 to 5 days before the women's period, that PMS that maybe they've never experienced before in their life, that they're starting to experience now. And that is usually because progesterone is not coming up as high as it did during those strong cycling reproductive years. It's not coming up quite as high, and so those drops can have an even bigger effect there. Also, the lower cortisol level in the luteal phase can lead to that feeling of fatigue sometimes experienced by women. They're not getting that boost of cortisol to help them feel awake, and really help to kind of smooth over the inflammation. So that can really be an important effect. And it's lastly, lower progesterone has been measured after ovulation in women who have higher stress. So progesterone is high, cortisol can be lower, but also if cortisol is high, progesterone can be lower. So it really does have this chicken and an egg effect with this relationship with cortisol and progesterone. Now, I want to call out that it's not a pregnenolone steal. Hopefully, we've done a good enough job here at Dutch debunking that myth for you, that the reason why progesterone is low with stress is that you need pregnenolone to make cortisol, and you need pregnenolone to make progesterone. And if stress is high and the need for cortisol is high, all the pregnenolone gets used up to make cortisol, and there's not a left for progesterone. That's completely not what happens. The pregnenolone that's used to make cortisol is in a completely different cell in the adrenal gland, whereas when the pregnenolone to make progesterone is in the corpus luteum. So it's in a completely different space. They're not pulling from the same pool. So it's not the progesterone steal, but it is a very real effect. And this is due to a complex interplay between cortisol and the HPA axis. So stress causes changes to the HPA axis and changes to the HPO axis. And also, it causes changes actually in the ovaries and in men in the testes. There's changes to the receptors for the brain hormones within the gonads for men and women when you're under stress. So you get this overall change in communication that can cause reproductive hormonal dysfunction when stress is really high. Now, I bring all this up because as the ovaries become less and less important for production of hormones, the adrenal glands become more and more important. So it can get really complex and complicated. Now, let's start to shift a little bit and talk about perimenopause. So in perimenopause, ovarian hormone production begins to slow down. But like I said, this is not a slow, gradual decline. It's in fits and spurts. One of my colleagues actually in a presentation, I will never, ever forget this comparison, but she said hormones in perimenopause are a little bit like squeezing from a ketchup bottle. You shake it, you squeeze. Sometimes you get nothing and you squeeze and squeeze and squeeze and it's just spurting and nothing's coming out. And then once in a while you'll get a good squirt and you'll get way too much ketchup on your hamburger. You know, that irregularity in production is really hallmark of perimenopause. And I love that visual to really make it stick. You know, some cycles, the ovaries are trying and nothing comes out. Other cycles can seem completely normal. Okay. I'd said this before, but perimenopause is like puberty, but on the other side of the reproductive years. But it's really unpredictable. And for many women, they can start to become very uncomfortable. You can see weight gain, you can see hot flashes, mood changes, and sleep disturbance. And those are the things we tend to see most commonly in perimenopause. So what's happening physiologically in perimenopause? First, you have the ovarian reserve begins to decline. So you have less follicles in the ovaries and less healthy follicles. You've used the most responsive follicles up first. So the chance of recruiting a healthy follicle for development diminishes. Now, I specialize in fertility. That's been a huge part of my practice. And I see this a lot because the majority of women I work with are 35 to 45 years old. And for some women, they start to see that impact of a declining ovarian reserve. Now, the aging ovaries and follicles will continue to secrete estradiol, but progesterone secretion starts to decline as well, and ovulation really becomes less predictable. So similar to puberty, it's more common to have cycles where ovulation does not occur, that anovulatory cycle. So even if bleeding is regular, the amount of cycles that have an active ovulation and release a follicle will start to decline. Now, when that happens, like I said, the ovaries are not responding the way they used to. The hypothalamus and pituitary gland upregulate, and they start to produce more signaling hormones to try to get a response out of the ovaries. So we see FSH increase. Okay, this is something that's measurable in women when they're trying to conceive at a later age. We always check FSH on cycle day 3. But that can result in irregular cycles and estradiol being either high or low, and it can also fluctuate in the same female. So we see hormonally lower progesterone, higher estrogen or estrogen dominance. Again, even if estrogen's declining, progesterone's declining faster, you could end up with that kind of estrogen dominant picture, and the presence of irregular cycles. And these are really the key hallmarks of perimenopause. Until eventually you have no cycles for 1 year, and then menopause gets diagnosed. At that point, you would expect to see very high FSH, oftentimes in the US measures it in the hundreds, and a very low estradiol and progesterone level. So the Dutch testing during perimenopause can be really helpful. We know women are starting to feel irregularity, starting to feel symptoms, maybe hot flashes and things like that. I tend to like to use the Dutch Plus or the Dutch Complete or the cycle map. The cycle map allows you to see the entire 30 to 45 days. Even an irregular cycle can be done with a cycle map. This can be tricky though, because cycles become more irregular. So you no longer have what we would call a typical cycle, a predictable 28-day cycle. So it's really important when it comes to testing, if you're testing a female in perimenopause, that you try your best to identify an ovulation. There's a lot of ways that can be done. You can use cycle charting by taking oral temperature. You can be using the ovulation predictor kit test strips that you can purchase at a pharmacy, or a lot of different apps will monitor for you. Like I have an Oura Ring, the Apple Watch will do it as well. And it basically takes a daily temperature. And when you see that temperature spike or elevate about mid-cycle, that's how you know ovulation occurred. So those can be really helpful when women are irregular, because you do want to try to catch 7 days after ovulation if possible. And that can be tough to do when cycles are not regular. Now, if you wanted to do a full cycle map or a cycle map paired with a Dutch Plus, that's definitely possible. And we have different guidelines depending upon the predictability and length of the cycle. So if that comes up, you can reach out to Nordic or to us, and we can help you field kind of how to do that test, how to have your patient collect the samples. And there are some basic instructions that will cover a long cycle as well, right in the kit instructions. Now, the other piece with perimenopause is that I love focusing on the HPA axis section of the test, because you can also evaluate other causes for the symptoms and changes women are experiencing, the mood changes, the sleep disturbance, the hot flashes even. It's really important to not just assume that the problem is related to estrogen and progesterone and perimenopausal change. We see that a lot of those same symptoms, weight gain, mood changes, things like that, they also come up when the thyroid is dysregulated, or when you have metabolic changes that are moving towards type 2 diabetes, for example, or when you're under a lot of stress and the cortisol regulation isn't happening the way that it should. So really getting that more global view can help you first make sure that a woman's symptoms are perimenopausal and not caused by something else. And two, even if you see that it is perimenopausal symptoms, looking at the HPA axis and working to optimize it in perimenopause sets a woman up for success during menopause itself. So here's an example of a perimenopausal female's Dutch test. So again, let's take a look at this the way we did the one for the cycling female. The first thing that we tend to look at is the estrogen and progesterone balance. So in this case, you can see that her estrogens are kind of all over the place. You know, this one is just squeaking into the normal range, her estradiol for cycling females. Her estriol is quite low. Estrogen's kind of in the middle of the postmenopausal and the postmenopausal and the cycling female range. Her progesterone on this particular test was in the postmenopausal range. So by this, we can say she didn't ovulate during this cycle. She didn't make any progesterone. But you can see kind of this estrogen dominant picture, even though estradiol is low, because there's so little progesterone secreted, that woman might actually feel estrogen dominant, even when the estrogen is low. Okay. The estradiol, you might see normal, you might see low. Progesterone, in this case, it's very low in the postmenopausal range, but you might also see it in this in-between range between the low star of the cycling female and the postmenopausal range. But those are the changes that you would typically expect to see. Now, androgens, you may or may not see changes in perimenopause, but really this one is a very good example of what a perimenopausal female would look like on the Dutch test. Now, in this case, this is her HPA axis, the same patient. This is really interesting because we talked about this before on the Dutch Plus. You can measure a CAR. The first 3 salivary tests are taken in the first 60 minutes. And there's actually really good published data on the CAR and how it changes as women get older. Generally, you'd want to see the difference, and I've lost my cursor here, the difference in cortisol between this waking value and waking plus 30, you want to see a 50 to 100% increase. So if she started at about 4, you'd expect to see her high here about 8. For this particular patient, it's only about a 25% increase from the waking cortisol to the waking plus 30. You can't see it so well on this graph, but if you look at the table pages of the Dutch test, you can see the actual cortisol value in measurement, and you can calculate that yourself. What this tells you is her CAR is off. Her CAR is too low. And that's a sign of a reduction in her resilience, her overall resilience. So even though she is really within the normal limits for cortisol, although she's quite low in the afternoon and evening, you could look at this, and if you weren't paying close attention, say, this actually looks okay. She's in the normal range. But if you compare the CAR, this is kind of the first thing to change. So I would say if you did nothing for this patient to support her cortisol and her HPA axis, you're probably going to see some problems down the line with her other cortisol measurements being out of range. So that's the first element we see here with cortisol dysfunction. Her CAR is too low. It's not rising up high enough in the morning anymore. So that's a note of low resilience. We also see the afternoon and night measures are very, very low. So she might be symptomatic at that time. I'd be curious about how that patient's feeling. And also, if we shift to the right, you can see that her total cortisol production is high, but her metabolism doesn't match. It's quite low. So what this means is she's not metabolizing and eliminating cortisol effectively. And there can be many, many causes of this with that low metabolism, but hypothyroidism is one that we see very frequently. And if I got this test back for a patient, I would want to check her thyroid, because it's very possible that her thyroid is not functioning optimally, and that's leading to this kind of mismatch. But what you can see with this is that even though her cortisol production looks low on this curve, overall, she's actually kind of high because she's retaining it. She's not eliminating it effectively, just like you want to eliminate those estrogens effectively. So in perimenopause, you want to really focus on the HPA axis function and how you can optimize it. When it comes to the estrogens and progesterones, you might notice a change or something that you could optimize, but in perimenopause, I wouldn't focus too heavily on those absolute values, because you could test it again the next month and have it be a little bit different with estrogen and progesterone levels. You do know you are going to be seeing lower progesterone, so that's one thing that you could work on. Some people like to supplement with progesterone as a hormone replacement therapy. When it comes to perimenopause, using even a cream form is fine for symptom management. When you get to menopause, it's not enough to protect the uterus if a woman's on HRT, but used alone, it can be helpful to kind of smooth out the bumps in perimenopause with things like sleep disturbance and mood change. A lot of women feel improvement from using progesterone alone when they're still cycling. But looking at the HPA axis function, it obviously in that last patient I showed you, there's a lot that can be done to optimize it. You could look at her thyroid function. You could consider stress reduction techniques. You could look at her day and how you could get patterns and routines put into her day. Of course, you could look at things like B complex and other botanicals. I love herbal medicine to help with HPA axis function. There's so much you could do, but now is a great time before a woman becomes menopausal to make sure that's shored up, because as she hits menopause, you're going to start to see that the majority of estrogens come from conversion of DHEA made by the adrenal glands. So we want the adrenal glands to be optimized and really functioning as best they can. Keep in mind, testing of collection might be more difficult if a patient's cycles are irregular, and you might note low progesterone or lower than in the past, even if the test timing is correct. But paired with that, you might see estrogens be high or low or normal. So when it comes to perimenopause, think about your overall goals with the patient, with why you're testing and why you're treating. So if it's sleep or mood changes, you want to think about that whole picture, how you can help her best, and how you can best position her to transition into menopause at the same time. Okay, so in menopause, the ovarian production of hormones ceases completely. And so adrenal production of DHEA with peripheral conversion, mostly in the adipose tissue, becomes really, really important. So menopause is a cessation of that monthly hormone cycle and fertility in women. The average age for menopause is 51, but the range is broad, about 40 to 58. The changes that occur prior to menopause are gradual, about 2 to 8 years, and oftentimes symptomatic, like we talked about. That's our perimenopause period. And then once the cycles have ceased for 1 year, 365 days, that patient's considered postmenopausal. Okay. But due to the fluctuation we talked about during perimenopause, menopause is not confirmed until cycles have ceased for 12 full months. So if you go 11 and a half months and you have another period, that clock starts over again when it comes to whether a woman is in menopause. Now, estradiol has a lot of important actions in cycling females. It's that considered that kind of classic female hormone, that queen bee hormone. And its most immediate action is to build and thicken the endometrial lining, but it also has a lot of other really important actions. It helps support bone mineral density. It reduces the resorption of bone. It increases the metabolic rate and improves insulin sensitivity in females. It helps maintain a healthy cholesterol pattern, supports memory and concentration and blood vessel health and elasticity of the epithelium, which can impact heart health and skin health. It also is critical for vaginal lubrication, and it helps to increase serotonin and activate serotonin receptors. So estrogen is very supportive of a good, happy mood. So when I'm talking about these things and all the benefits of estrogen, hopefully you're naturally thinking about, well, gosh, when estradiol declines, all of these positive actions could be impacted, and we could see changes there. Similarly with progesterone. Now, this is our other kind of female hormone made for about 12 to 16 days after ovulation, and its main job is to stabilize the endometrium. So in a cycling female, I always think about it that estrogen builds the bricks. Progesterone is the mortar that glues them all together. You need both of them for a healthy endometrium. But just like estrogens, progesterone has a lot of other benefits for females. First of all, it binds to GABA receptors. Progesterone and many of the progesterone metabolites do. We talk about the alpha metabolite, which does have very strong binding, but many progesterone metabolites bind to GABA, even ones we don't test on the Dutch test. So it can be very relaxing and calming. It also can help promote sleep. It increases our metabolic rate. You can measure this if you've ever done cycle charting. This is why you see that boost in body temperature after ovulation. It's because progesterone increases our metabolic rate. It also positively impacts bone mineral density. It can downregulate estrogen receptors, which is great. So you don't get that estrogen dominant picture. and it induces the enzymes we need to break down and metabolize estrogens. So progesterone has a lot of other really important factors. But again, what we see here is that during that perimenopausal transition, you see this decline of progesterone over time and that spurting of estradiol. So I do want to focus just one more time on this spurting with estradiol, because you can see that during the perimenopausal periods, you get spikes in estradiol that might actually exceed that woman's experience in reproductive years. I want to highlight just how much estradiol can be secreted during perimenopause during those fluctuations. So if estradiol is screaming high when you do a Dutch test, it might not be some kind of outside exposure or HRT or anything like that, that you might just be catching one of those peaks in the cycle that you're measuring. So perimenopause is irregular cycles, lower progesterone, it's unpredictable or absent ovulation, and variable levels of estrogen, high on some days, low on some days. With menopause, the cycles stop completely. This is diagnosed after 12 months with no cycle. And in menopause, you'd see consistently low progesterone and estrogen. So you can see that down here, very low all the time, no more fluctuation. And also the symptoms that are supported by estrogen and progesterone start to experience a change. And we see accelerated aging once women hit menopause as well. And then postmenopause is the phase of life after menopause. Nowadays, thankfully, with this long lifespan, women are living decades after menopause. Again, just a reminder that typical age, 45 to 55 years, the menses is absent for 12 months, and you don't need to do labs to diagnose menopause. You can base it off of that last menstrual period, but a lot of providers like to diagnose menopause. So what you would expect to see in serum testing is a high FSH and a low estradiol in the same measurement. That would indicate, along with the history that it's above, that woman's in menopause. So most of the time you don't need to do that testing because you have the period to be monitoring, but you might need to do lab testing. Like if a patient's had a hysterectomy and they no longer bleed, then you might run labs to confirm, are they in menopause or are they not? It's important to note estradiol alone is not a diagnostic factor for menopause. You need that high FSH paired with it. I really like to share this chart. This is called the STRAW. This comes from the STRAW workshop, which is stages of reproductive aging, which outlines the female hormone stages and symptoms that they might experience. And again, if you're taking a look at this, this looks at some of the labs and supportive criteria that you might see, and also the symptoms that you might see as well. And when we look here, we're looking at the final menstrual period here, which really transitions from that menopausal, perimenopausal transition into postmenopause. Okay, this and highlighted here is what we would consider that perimenopause. And most women experience symptoms and changes throughout perimenopause and into menopause, and then also in postmenopause. Now we talked about kind of that normal menopausal experience, but some women do go through menopause early. That would be ages 40 to 45. If a woman is not menstruating during those ages, you can't just assume it's menopause. You want to rule out pregnancy, hypogonadism, high prolactin, or hyperthyroidism. But about 5% of women will experience menopause early without any pathology. So you might still see it in your practice. And in addition to this naturally occurring menopause, you also can see other kinds of menopause. So you might have women who have primary ovarian insufficiency, or POI. This is premature menopause, and it's oftentimes diagnosed during a fertility workup when women are having trouble conceiving, where they might be in their 30s, for example, but have labs and have ovarian function more similar to a peri or postmenopausal female. The other instance of this would be a surgical or an induced menopause. Surgical would be that you have both ovaries removed for some medical reason, and induced could be something like chemotherapy that causes damage, or radiation that causes damage to the ovaries that would put a patient into menopause. These women I like to bring up because they're not the majority of who we see, but I like you to have awareness of it because they require special consideration. And in the cases where women have POI or surgically or medically induced menopause, when it's young, like all of the association's guidance is to get them on hormone replacement therapy, at least until the age that they would have naturally gone through menopause. And that's for bone protection, heart protection, all of those other pieces that are really critical. Okay, we've kind of talked about that piece already. So once menopause hits, the ovarian estradiol and progesterone stops irreversibly. Those ovaries are never going to make them again. The ovaries do continue to produce testosterone, though, interestingly. But what we see here is that the adrenal glands become really important. They produce DHEA, DHEA sulfate, and androstenedione. And then those circulating levels of testosterone, DHEA, and androstenedione get aromatized into a small amount of estrone and estradiol in the outside tissues, mostly in adipose tissue. And so in menopause, the androgen are being aromatized into estrogen in adipose tissue is our primary source of estrogens. About 99% of our estrogen in postmenopause comes from adrenal DHEA. This is what I was talking about before when I talked about perimenopause and the importance of healthy adrenal glands and healthy production. If you see a female in perimenopause with low adrenal DHEA and HPA axis dysfunction, it's a great time to fix it because you have a greater reliance on adrenal glands in postmenopause. Now, interestingly, in my undergraduate, and I did like a biochem degree, but I also did a medical anthropology seminar and kind of study as well. And one thing that I found fascinating is that many traditional cultures, like the Kung tribe in Africa and all these kind of still hunter-gatherer cultures, females don't experience menopausal symptoms. They have cessation of menses, but the rate of things like hot flashes and mood changes are extremely low, like really not reported. And that's so fascinating to me now that I'm a doctor and I've learned a little bit more about what happens physiologically, because I think about their life being more traditionally aligned with how our stress was intended to be. You know, you have bursts of high stress, but then most of the time a period of low stress during our life, and probably much more well-regulated HPA axis function. I don't know if that's ever been studied, but we should take a look at that and do Dutch testing on traditional tribal cultures and see what things look like for their HPA axis. But when you see these traditional cultures not experiencing symptoms, they're getting the hormonal change without production of symptoms. It really makes me think about what's different about that lifestyle and that kind of more traditional life. Also, probably traditional diet, tons of movement and walking, how all of those things can positively influence women as we transition to menopause to do it in as easy a way as possible. Now, some of the symptoms we talked about in perimenopause, you'll see short or irregular cycles with fluctuating symptoms. Women might get heavier bleeding. We've talked about mood swings, weight gain, hot flashes, night sweats, things like that. Now, in menopause, these become extremely common. Hot flashes, about 76% of females report. Disrupted sleep, just slightly underneath that, about 66% of women report that during menopause. Low libido and vaginal dryness, you can see just around 55-60% of women report. And then about 30 to 50% of women report different kinds of mood changes, depression, irritability, and anxiety. And these would be symptoms that would be new for those women. But menopausal hormone changes are also associated with increased chronic disease risk. So even if a patient's not symptomatic or complaining about a problem, as their provider, you want to be thinking about risk management long-term as well, particularly because thankfully women are living decades after menopause now. So we want to think about heart health, diabetes prevention. Osteoporosis is a big one because post-menopause, they're not going to have that bone building anymore. You're really on the decline. So you want to think about slowing the decline there. Weight gain, higher rates of gallbladder disease, arthritis, arthralgia, depression and anxiety, and insomnia. Now, those adrenal hormones, like I said, they're really critical for us protecting all of those symptoms. So you want to make sure there's robust adrenal DHEA produced. And in chronic stress or low adrenal output, you might see higher menopausal symptoms. So this is why we need to address that in advance. Now, when the cortisol circadian rhythm is dysfunctional, that can also negatively impact sleep, metabolic health, heart health, inflammation. So when you layer on a dysfunctional HPA axis with menopausal changes, it's like a double attack for females. So you want to make sure that those are being addressed. And lastly, melatonin does seem to decline in some women once they hit menopause. So again, making sure, and that melatonin is something we test for on the Dutch test. It's measured in urine. So that's another thing to be thinking about, is monitoring that over time, thinking about supplementing or how you can support good sleep. Now, melatonin is not just critical for good sleep, it's also a really, really important antioxidant. And, acts kind of in conjunction with like vitamin D on that kind of daylight nighttime cycle. So really critical hormone for us. So why might we run a Dutch test in menopause? First, you're able to see the low estrogen, low progesterone. That's kind of a given. You'd expect to see that. But you can look at estrogen metabolism. You want to make sure that estrogen is really efficiently metabolized if your patient is considering hormone replacement therapy. So if estrogen metabolism is off and the woman's estrogen is very low because she's postmenopausal, that might not have a detrimental effect on her health. For example, the amount of 4-OH she's making, which is that kind of harmful active metabolite, even if it's the predominant metabolite for her, if her total estrogens are so low in postmenopause, it may not have a clinical impact. However, if she's considering hormone replacement therapy and you add exogenous estrogens into the system, then it becomes very clinically relevant. So you might want to work to actually fix that and repair that and optimize that before putting a patient on HRT. Also, androgens and androgen metabolites. Now, this is when androgens become so important. It's females with PCOS, but then postmenopausally, really important. When we look at the androgen metabolites, we can see the androgen activity in the cells because with Dutch test, we're looking at urine. It has to go into the cells and be metabolized before it comes out into the urine. So we actually can look at tissue levels when it comes to androgens. And circulating androgens, remember, are our sole source of estrogens. They're going to impact libido, mood, and muscle mass. So if you're working with a patient postmenopausally who doesn't want to do HRT, you need to make sure her androgens are really well optimized because without androgens, she's not going to make any estrogen. And then lastly, like I'd mentioned before, I love looking at the HPA axis and the adrenal panel because if there's low adrenal output, that would be low androgens, she's going to end up with even lower estrogens, even lower than most women in menopause. And the lastly is that when we look at the CAR and we look at the overall curve with cortisol, that's a measure of resilience with aging. So I really like to focus, especially because a lot of women seek healthcare during this perimenopausal, postmenopausal time where they might have put things off because they were working or mothering or had other priorities. They're finally prioritizing themselves. This is a time where you can really focus on helping them improve those things. So why Dutch test? The serum levels show a snapshot, and so does saliva, where urine shows it over the course of an entire day. We do a 4-spot urine test, and we've published to show that it parallels a 24-hour urine collection. So you're able to get kind of smoothing out of the bumps there. You can see that here. These are studies that look at serum time points with HRT of an estrogen gel and an estrogen patch. And when you look at just a single time point, you might measure it here or here and get really different impressions of where a patient's estrogen is. But if you do a Dutch, you're looking at an average over the course of this whole 24 hours. So you get a really good viewpoint there. We also published on this last fall in Menopause, which is the premier journal for OBGYNs. It's probably the top tier journal for menopause. And they accepted our paper that compared the estrogen exposure on different kinds of estrogen replacement therapies measured with the Dutch test. So this really highlights the clinical utility and validity of Dutch testing when it comes to measuring hormones, even when it comes to measuring hormones in patients who are on therapy. What we can see here is that when women are on therapy, depending upon the dosing that they're using, they'll rise out of the postmenopausal estrogen ranges. And if you get high enough up into what we see in the premenopausal, but symptom relief tends to be pretty good, moderate at these low dose levels. And as you move up in this in-between range, we see those higher dose therapies be really effective. We've converted that, if you're using the Dutch test today, to kind of overlay what that would look like. The purple is the postmenopausal range. And normally you would see a star right here. And what we tend to see is when doctors are putting patients on hormone replacement therapy, we recommend that they aim to see either between the purple and the green or in the first third, that lower third of the green, that kind of low to mid dose therapy range. That's where we tend to see females. Again, this is for on hormone replacement therapy. And if you put a patient on hormone replacement therapy, these are the targets that you'd want to be taking a look at, both in serum, which is kind of the gold standard, as well as on the Dutch test. Now, I'd mentioned this, that with Dutch testing for women in postmenopause, you're able to take a look at estrogen metabolism patterns. It's really important to do this, especially if you're going to be putting a patient on any kind of hormone replacement therapy or even herbs to try to boost estrogen levels. We want to make sure that they're metabolizing those effectively. So I want to just, in kind of closing our last few minutes, run you through an example. This is a patient that I did put on hormone replacement therapy, but to kind of walk you through how we would use a Dutch test throughout different stages of that process. So before I would initiate any kind of therapy, whether it's natural, lifestyle, hormone replacement, I'd want to run a baseline test. This is the baseline Dutch complete. So what I see here is that her estrogens are in that postmenopausal range. She's actually at the low end of the range for that. So even for a menopausal female, she's low. I think her estrone at 2, that's even below the normal range. But her estrogen metabolism patterns all look okay. Okay, that looks fine. And when I look at her progesterone, again, she's in the postmenopausal range. So this is what you'd expect to see in a postmenopausal female. Now, I also looked at her androgen levels, and they're all also below normal, even for her age. So we have this table here. This is on the Dutch test that shows the age-dependent reference ranges. So she was 51. So we'd be looking at these yellow bars. Her DHEA should be between 30 and 350, and she's at 15. Okay, really, really quite low. Her testosterone also, she should be between 2.3 and 8, and she's at 0.5. So she might be feeling particularly worse because her androgens are lower. And this also explains why her estrogens were even lower than most postmenopausal females. She has no androgens to build them from. Okay, so when it comes to treating, in the United States, we have DHEA as a supplement. So that's an easy way that I could give her DHEA to try to raise her androgens and try to raise her estrogens without hormone replacement therapy. But there's also herbs that can be helpful for this, like maca, or others that might help with that production of more androgens for her. Also, I think the root cause of this was her HPA axis is off. You can see that here. Her cortisone production is extremely low and just kind of low throughout the whole day. So we see low, total DHEA is low. You can see that here. Her cortisol is low. Her metabolized cortisol is low. She really doesn't have much of a diurnal pattern to her cortisol. And her overall, she just has this low end adrenal output. And that's probably contributing to why she felt so cruddy and why her estrogens were just so low. But really, this is what I would say the root cause was. And so this is why I love to look at a Dutch test for women in postmenopause, because this is a really different problem than a female who has adequate androgens, a healthy HPA axis, and low estrogen and progesterone. And the approach that I would take would be really different. For this patient, for root cause, really looking at HPA axis is going to be critical. I also looked at her oats. This is that kind of bonus page I talked about. And for the most part, her organic acids are all within range, except for her norepinephrine and epinephrine metabolite, VMA. This one is an adrenaline metabolite, which is above range. And so adrenaline and VMA will go up with stress. Stress can worsen hot flashes. And also, it's really affecting her HPA axis. So stress reduction techniques would be a really critical piece of her overall protocol. Thankfully, she was really game for that. She was into trying it. And we did a 12-week mindfulness meditation program for her. Now, with this patient, I also used a hormone replacement therapy to try to get her symptoms under control faster. I'm not sure if that's in scope for you. I'm not what type of provider you are. But in this case, I started her on a very low dose patch of estradiol paired with oral micronized progesterone. So when you have a patient, really the estrogens are what you're using to treat the symptoms, but she still had a uterus. So you have to pair it with progesterone in order to protect the endometrium from getting too thick and causing problems like hyperplasia or cancer. So we're not talking about prescribing HRT today. I'm not going to get into the details of this. I just want you to see how things play out with the Dutch test and how you can kind of use it at all different stages there. So we put her on hormone replacement therapy and we did that stress reduction course. We also used, multivitamins for her and herbal medicine to help with HPA axis function. And then we waited 4 weeks. Now, symptoms can take 8 to 12 weeks to stabilize on HRT, but she was feeling pretty good, pretty stable at that point. Not perfect, but still better. So we reran that at 3 months. We also checked in on her estradiol levels in her blood. And we saw that she's kind of in the low range, but the normal range now for on therapy females. Now, in this case, we can see, I know this looks like a very minor change, but if you look at estradiol, for example, remember before she was at 0.22, the very bottom end of the postmenopausal female range. Now she's at 0.94, which is in between postmenopausal and cycling. And that's kind of a golden spot. If women feel good there, that's great. That's a great target. Her estrogen metabolism still looks really great. We're not seeing this elevation of 4-OH. Everything looks pretty good there, and her methylation looks excellent. So even on estrogen therapy, I'm not worried that that estrogen is going to go down a bad pathway and cause damage for her. Now, when we look at her estradiol, let's focus in a little bit on that. You can see she's kind of within that range for that low dose estrogen therapy, but her hot flashes were not fully resolved. And so with her, we decided, okay, well, there's still some room in regards to safety without feeling like we're getting her too high. If this is kind of our target range, she's at the low end of it, let's bump her patch dose up a little bit. So we bumped her patch to 0.0375 milligrams. At that point, she said her hot flashes have improved to the point where they like really never ever bother her. And so we waited another 3 months, kind of let that all settle out, and then retested her. Now, in this case, you can see her estradiol is almost in that cycling female range. Her metabolites still look really good. And so phase 1 and phase 2 estrogen metabolites look great. So this looks like a patient that's in a sweet spot. She's feeling really good, etc. Her progesterone is also within the normal ranges here. It's important to know if you're using progesterone to protect the uterus on HRT, you can't use Dutch testing for that or any lab test. You have to just go with the doses that have shown in clinical studies to be helpful. But you can look at progesterone metabolites to compare alpha and beta pregnenolone. This alpha metabolite can be really beneficial for modulating mood and sleep because that alpha metabolite can bind to GABA in the brain. She has a slight preference for it, but definitely it's looking great. So we want to make sure that that's in good range as well. Now, when we look at the HPA axis, she's had a little bit of a bump here. This is slightly higher, but it's still quite low. And so at this point, I would really want to keep working with her on the HPA axis, or I could think about adding DHEA. You can see her DHEA is still at the very low end here, and that would just depend upon her preferences and her treatment goals. When we look at her organic acids, the other thing that's interesting is that VMA metabolite has normalized. So it looks like the stress reduction technique has been really helpful to reduce her output of adrenaline. And that probably has also contributed to her feeling so much better with the hot flashes. So thank you guys so much. We have just a few minutes left on time, and I'm happy to stay a few minutes late to answer any questions, but hopefully that was helpful as an overview for you as how you can understand how the Dutch test can be applicable for women in peri and postmenopause. Oh, I'm not able to hear you. I think you're muted.
Absolutely, I'm here. Thank you very much for your presentation. That was excellent. And I think what was absolutely just needed, everyone give a high up or thumb or a heart or something so that, yeah, we can feel this energy that has been moving on. Of course, there has been lots and lots of activity on the side, and I have tried to take track of them. And so I understand, like, this is a description of the test, etc., and going into treatment, that would take a long time to discuss that now. And there were a few questions on like specific treatments. So I'm just, yeah, I'm kind of, I think we will open up for some education around more clinical treatment strategies for you all, since that is kind of not the scope of this discussion. So there was, and then there is, because without supplements, etc., like in regards to increasing DHEA, there was a question around that. But then you said you only use you didn't say you only use DHEA, but are there any other way in increasing testosterone without supplements?
There are. So this is a really common piece of treatment for women in menopause. So I love talking about this. And there's actually so much that's been studied that can be really helpful. So when it comes to females, when they're hitting their 40s, I really like to make sure they're focused on eating enough food, first of all, because so many women undereat. I mean, women should not be eating 12 or 1,300 calories per day. If they're eating that and they're still finding they're gaining weight, there's some other kind of metabolic issue going on. Making sure they eat enough protein specifically with that. So generally, you'd want to be looking at your target weight and eating about, well, in pounds. So about 1 gram of protein per kilogram, at least at a minimum. I like to see more like 2 grams of protein per kilogram of body weight at the ideal body weight. And then the other thing is getting women into weight training. And I think that that's really the narrative's shifted for women. I mean, I think we are like the victim of the 80s, 90s cardio phase, right? Where it was cardio, get on the treadmill, do more. But actually, in order to preserve body, the metabolism and the kind of the body shape that we want, women need to put on muscle. It's also critical for bone protection, for metabolism, for hormone balance, for androgen production, for growth hormone release. All of that is really tied to weight training. So generally, there is a protocol that's called, let's see, I'm going to mess it up. It's 5 core exercises, 3 sets, 10 reps. So it's the 5-3-10. And there's been good studies in men and women on this, where you're focused on core muscles. So it's like squats, lunges, shoulder press, bench press. I can't think of the 5th one off the top of my head, but it's using all of the core muscles and doing 3 sets of 10 reps a piece, where you're trying to use weights enough that like by 9 or 10, you're moving to failure. It's great for women to be doing that. The other piece of it that I see is problematic is right now, there's a big culture of like HIIT training, that high intensity interval training and cardio. And that's fantastic for cardiovascular health. However, if women's HPA axes are under strain and they have adrenal dysfunction, HPA axis dysfunction, I find personally for most women, it's too much. And more times I see patients come into me, women who are trying to be conscientious about their health, and they're doing CrossFit, they're doing HIIT training, and they're doing cardio. And it really becomes a strain on the HPA axis, and you have to get that system fixed. So what I typically do is like deconstruct and reconstruct educational workout plans for women. So I will have them doing weight training 3 to 4 days a week, and then walking 30 minutes a day. And walking is the only cardio. If they want to walk more, they can. Once their HPA axis looks good, you might add 1 day or maybe 2 of a high intensity cardio activity, boxing, HIIT training, things like that, but for no more than like 20 minutes a day. And just as women are in perimenopause, we need to kind of stabilize our stress release systems and work on tissue building and tissue repair. Those are the key strategies that I've found will help women naturally improve testosterone levels. And it's incredibly impactful. So I always start with those lifestyle factors. And then if I need to, I will think about herbs like maca is a favorite that I'll utilize. And then we also, like I said, we have DHEA as a supplement here. So it's just over the counter, the same way that herbal medicines are. Those are really the biggies that I would be thinking about for my patients. But I always start with lifestyle, the stress management, nutrition, and weights. And that can be like, get a good trainer that you can refer people to if that's not your bag, because it can really, really help women.
Now, this is very kind of like a very elegant wrap up that you just did there. And that's it ends up being a very long conversation around lifestyle when you do a Dutch test. And there isn't like, of course, there is a hormone replacement therapy, but that isn't a quick fix unless you also have the rest. It might, of course, there's some women who feel, oh, that was just it. But you can get very far looking at all the lifestyle adaptations. and make the women feel even better through that, without even going to the hormone replacement therapy area. So I think with that, also because time is ticking, I think with that elegant answer that you just did there, I think we should finish the call now. And you will be invited back again for sure. It may be on a different topic, but and we will also share some other educational material with you in the coming time. So yeah, we will send out the recording for this webinar to you, and the slides as well, so you have them. There were some excellent notes for your desktop reference guide for sure. So thank you, everyone. We managed to reach over 200 people live, so that was really nice. And Dr. Smeaton, thank you very much for a quick standing in, but I don't think we could have asked for anything better than what you just presented now. Thank you very much.
Thank you for having me.
Bye, everyone. Enjoy your evening.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.